We're going to cover stress testing today, and stress testing is going to be utilized as a non-invasive type of examination to assess the risk of coronary artery disease and potential arrhythmias associated with the electrical conductivity of the heart. And when we do stress testing, it's about 85% accurate that it's either going to give a true positive or a true negative. And so again, it is a good screening tool. You'll see stress tests used for people that have chest pain or have a history of heart disease, and now they're getting a yearly physical because they want to follow up with their cardiologist and have baseline information. You also may see stress tests used for people with certain jobs like firefighters or state troopers, those people that have, physical or at least potentially physical jobs that need to be at a certain level of fitness to be able to complete the tasks associated with their job. And again, it is a non-invasive procedure, which of course it means there's no penetration of the skin like it would be to assess the coronary arteries with a cardiac catheterization, where they would actually have to go in through the femoral artery, thread a catheter up through the arteries of the heart, and then inject dye into the heart. Now, before we get to any of the stuff that's on the board, when we perform a stress test, we need to make sure that we identify the correct patient. We need to use our two identifiers. We need to use name, date of birth, last four of the social security number, or whatever the office policy is. It may be that the office policy does not want to use last four digits of the social because they may not want to have any of that information out there. Okay, so secondly, once we've identified the patient, we need to explain to them exactly what this procedure entails. We need to tell them that we are going to prep them for a stress test that's going to involve placing electrodes on the chest. If it's a male, you may need to tell him that if you are hairy on the spots where we have to put the electrodes, we will have to shave you to get best electrical conductivity. You also may tell them that we're going to have to abrade the skin just a little bit to get good contact with our electrodes. That's called pinking them up, and we'll talk about that here in a bit. And then you need to tell them about the test itself. You're going to be walking on the treadmill, and there is some potential discomfort associated with walking on the treadmill. We're going to try to make you work harder on this treadmill than what you would under any normal circumstances in your daily life. That way the patient fully understands what exactly they're getting ready to do. You also want to tell them that while they're exercising, you're also going to be monitoring all of their vital signs, their blood pressure, their oxygen saturation. You're going to be assessing the EKG. You're also going to be speaking with them. You want to find out what's going on with them, if they're having any chest pain, any shortness of breath, any nausea, if they're getting vertigo. If they have any of those signs and symptoms, you obviously want to document those. But you want to tell the patient to freely speak if they start having anything that's out of the ordinary going on. Some perspiration, the heart rate increasing, all of that's to be expected. But if they have anything out of the ordinary, then you want to make sure that they bring that to your attention. Now, we've learned how to do a resting EKG. With the treadmill stress test EKG, we have to have them stand up. Obviously, walking on the treadmill, you're going to be upright. And so to make the test as accurate as possible, we want to put the electrodes on where they are likely to fall when the patient is vertical. If we have them lay down and then we have them stand up to walk on the treadmill, if somebody has excess tissue, those leads may not be as well placed when they're actually on that treadmill. When somebody is just resting, it's fairly easy to do the stress test, but we want to make sure when the person starts exercising, starts moving around, and when they start perspiring, that those electrodes are where they need to be to give us the best reading. Because we need to have a diagnostic quality graded exercise test or stress test. Okay, it must be diagnostic quality. The EKG, as well as all the information, needs to be diagnostic quality. So we're going to hook a belt around their waist, and that's going to hold the EKG lead wires. Okay, then once we have that belt hooked around their waist, we're going to place the electrodes. Okay, with the stress test, We're obviously not going to be able to put our limb leads on the wrists and on the ankles. We're also, because of the way the belt sits, you're not going to be able to put it on their anterior iliac crest either. The leg leads are going to be in line with the midclavicular space on the lowest rib of the rib cage. Okay. Arm leads in that hollow spot under the clavicle, midclavicular line. Okay, that's a typical stress test lead setup. Okay. Now, when you go to place those electrodes, again, if they are a male, you're going to have to shave them. Okay, regardless. Okay, and this is the razor. This is a safety razor that typically would be included in the kit that you would use for prep. When I say pink them up, this is some gauze that's infused with pumice. Pumice is lava rock. Okay, and you would use that to abrade the skin. Our epidermis has 20 to 40 layers of dead skin cells that contain all the body lotion that we put on, plus our natural oils, the sebum that we produce to lubricate the skin and lubricate our hair. And so we got to get that off there so we get the best conduction possible. So you would probably use one of these small gauzes with the pumice ingrained in it. You'll also use a different type of electrode. Okay, it's much larger, so it covers more surface area. On the back, if you were to feel this, you can feel it's kind of squishy. There's a lot more electrolyte conducting gel on the back. There's also more adhesive. Okay, the person's going to be sweating, plus the weight of the device itself is going to be pulling down because they're vertical. So we have to have a bigger electrode. Okay. Now, once we get the patient hooked up, we got a few things that we need to do. Okay, we're going to have to get baseline information when they're supine. Okay. We may also want to use this time to calculate their target heart rate, okay, which is their maximum heart rate that somebody can attain for their age. To do this, we take 220 beats per minute. Okay, 220 is the theoretical max that the heart can beat without going into fibrillation. Then we subtract their age. In my case, 47. So 220 minus 47 is 173 beats per minute. That is my maximum heart rate. Ideally, we would like this stress test to get me up to the maximum. Now, some physicians may only want to go to 85% of the max heart rate. Okay, in that case, once you find the max, in this case, my example, 173 beats a minute, you take 85% of that, 0.85, that comes out to 147 beats per minute. Okay, so depending on who your physician is, you want to know, are they going to take the patient to max or are they going to just stop at 85%? Ideally, I liked it when my cardiologist would take the patient to max. If you're going to go out in that first heavy wet snow of the year and you're behind schedule to get to work and you're shoveling like crazy to get your driveway cleared off and you're clearing off your car, that may be too much stress for the heart. Okay, I would like somebody to be stressed harder than they ever would in anything that they would encounter in their daily lives. Okay, so in the presence of a cardiologist with a highly trained staff, that's the time to have some sort of a cardiac episode versus, getting out there and shoveling and then having that episode. So it's really the best if the physician takes them to the max. But again, it's going to be up to them, and you would need to know what their protocol is. Now, what we're going to do once we have them hooked up, once we found out what their max heart rate is, we've got to get baseline information. This is going to give us a comparison for what is the change from rest to when they're at maximum heart rate. Okay, and then ultimately, once they get to max, we can't turn them loose till everything comes back to baseline. Okay, so this is going to be very important information. All right, so I'm going to be the patient now. I'm going to end up having you guys as my medical assistant. So we're going to do baseline data supine. Okay. Now, you've got me all hooked up, and you've got a resting EKG that's running right now. You're going to get my blood pressure. You're going to put the probe on my finger and assess my oxygen saturation. And after we have a few minutes of the person in the supine position, then we're going to have them move to a seated position. Now, ideally, you'd like to have them lying supine for a few minutes, but your schedule may say otherwise. You may just have a chance to essentially have them lie down and then have to do all their vital signs. Okay, but again, ideally, I would like for them to be resting here 5 to 10 minutes before we assess their blood pressure, their EKG, their pulse oximetry. Now, once we do have that baseline information, the next thing we're going to assess is having them go from supine to seated. Okay, supine to seated. Many times when people go from flat to seated, they will have orthostatic hypertension. Okay, and you can see up there on my board, I have baseline information first, supine. Then when we go to seated, we're looking out for orthostatic hypotension, a drop in blood pressure greater than 20 millimeters of mercury. We're also going to be running EKG, using the finger probe for the pulse oximeter to get that reading as well. We want to talk to the patient too. Mr. Bernard, did you notice that you felt dizzy or lightheaded when you went from a lying down position to a seated position? We need to assess all of that. Okay, we don't want to get our patient up on the treadmill and then have an issue. Now, the other thing too is, once you put the blood pressure cuff on the patient, when they're supine, you're going to leave that cuff on them from here on out. Okay, you're not going to pull the cuff off of them every stage of the treadmill. Things are going to pick up pretty quickly when we start doing the stress test, and we don't have time to keep realigning the cuff. The other thing too is, when you go from flat to seated, you don't want to lose that precious little bit of time when you're assessing that blood pressure, because they may actually reset and not show that decrease in blood pressure if we wait too long. So have the cuff on their arm, don't have it fully inflated, but have it pumped up just enough so it doesn't slide down their arm or roll around. Okay? Then when they go from flat to seated, pump it up the rest of the way so you can very quickly get a reading and assess if they are orthostatic. Again, if they drop more than 20 millimeters of mercury on the top end, the systolic, they're orthostatic. After we get seated, then we're going to do standing. The exact same thing. We want to make sure that they're not orthostatic. EKG, blood pressure, pulse oximetry reading, same drill as flat to seated. Keep the cuff a little bit inflated so when they go from seated to standing, we've got a good reading. Okay? Now, once they have completed that, we're then going to have the patient hyperventilate. Hyperventilating oftentimes causes changes with their ST segments. Those changes could be indicative of the fact that they may very well have an issue when they get on the treadmill. Okay? So we're going to have them hyperventilate for 30 seconds, and it's not easy to do that. So you may have to coach them, prompt them to keep going for the entire 30 seconds. When that 30 seconds is over, again, you're going to have the cuff already on their arm very quickly. You want to assess their blood pressure.
And you want to make them hyperventilate when they're sitting down.
Yes, you don't want them standing because they very well could pass out. And again, you're going to need to talk to your patient when they are done hyperventilating. You want to make sure that they're not dizzy or lightheaded. Okay, so Mr. Bernard, we need you to hyperventilate for 30 seconds. So I would do 30 seconds, and then after that, you want to make sure that you assess all of my vitals: EKG, oxygen saturation, blood pressure. Okay. Now, at that point, it's going to be time for us to start the stress test. Now, stress test treadmills are a lot different from this commercial treadmill that we have here. All this treadmill can really do is what we program in. It's not set up necessarily to be a stress test treadmill. Stress test treadmills have the protocol already programmed into it, so all we have to do is hit one button. Okay, the protocol that we will use is called the Bruce protocol. The Bruce protocol is 3-minute stages, and at the end of every 3-minute stage, the speed and incline increase. The first stage of the Bruce is 1.7 miles per hour and 10% elevation. The second stage is 2.5 and 12. The third stage is 3.4 and 14. The fourth stage is 4.2 and 16. The fifth stage is 5.0 and 18. The sixth stage is 5.5 and 20. And then the seventh stage is going to be 6.0 miles per hour and 22% incline. Okay, and again, that was on the board, so I want you guys to just be familiar with the protocol. I'm not going to ask you to memorize all of those settings, but just be familiar with it. The speed is not so dramatic at first, but the incline really takes its toll on people's legs. So a lot of times people will get fatigued very quickly when they're doing their stress test. Now, these stages are in 3-minute increments. At the 1.5-minute mark, the midpoint of each stage, you need to assess the patient's blood pressure, their EKG. You need to speak to them, ask them if they're having any chest pain, shortness of breath, any other signs and symptoms. You want to get their pulse oximetry reading. And up here on this wall chart, I've got what's called the RPE scale. The RPE scale stands for Rating of Perceived Exertion. How hard do they feel that they are working? That gives me key information as to how much longer this person's going to last on the treadmill. If I'm in the first stage, which is 1.7 miles per hour and 10% incline, and they're already rating it as very hard, a 9 on a 1 to 10 scale, chances are I'm not going to have that patient last long enough to get their heart rate up to 85 or 100% of their maximum heart rate. So that RPE gives me a lot of insight into how well my patient is doing, how much more time they have. I may also need to be coaching them, prompting them to keep doing as much as they can. Okay, you're going to find out that stress testing is not easy. And you're going to have to coach your patient, cheer them on, so to say, to get them to perform at a high level, because it is fatiguing to do a stress test on the incline that you're asked to perform with that Bruce protocol. Okay, it is very intense.
When would we consider doing the one where we give them an injection to make their heart do what you would do on there?
If you have a patient that maybe has some sort of a physical limitation,
Like amputation?
yeah, that'd be a good example. Amputation, sure. If they can't walk, the only way they can ambulate is with a rolling walker, for example. Then those patients, we would want to use a chemically induced stress test, a persantine test or dobutamine test. But ideally, we would like our patient to walk on the treadmill. Now, a couple other things that I want to tell you all. When you go to get your patient on the treadmill, you want to coach them how to walk on the treadmill. That's important. Okay, a lot of people have never walked on a treadmill, and so you need to tell them how to do it, show them how to do it, and then when they get up here, make sure that they fully understood the directions you gave them and step on the treadmill properly. I'm going to go ahead and start the bell. Now, your patient, they may not have ever walked on a treadmill before, and so what you're going to tell them to do is hold on to the handrail, stand with one foot on the side of the treadmill off the belt, and just gauge the speed of the treadmill with their other foot, and then when they feel ready, just to step on. Okay, that's very important. You'll see a lot of people stumble when they first get on a treadmill because they're just not used to having the pavement move underneath them. So again, you want to coach your patient on how to step onto the treadmill. Okay. Now, what I want to do is have you guys, okay, Kendall, let's have you, okay, Madeline and Sheila, let's have you guys, you're going to help us out for the stress test. Okay, and what we're going to do, I'm not going to go through the whole stress test, but I want you guys to have an understanding of everything that we have to do in the 3 minutes that we have on each stage in the Bruce. So go ahead and come on up and bring your stethoscopes with you.
Under my car.
All right, so what I'm going to do is have one, and let's assume that we've already had supine, seated, standing, and hyperventilating vital signs on the patient. And now we're ready to teach them how to step on the treadmill. Okay, you have taught them how to step on the treadmill, and we're going to start the assessment now. Now, what I'm going to do is use the timer on this treadmill for our 3-minute stages, but keep in mind that a stress test treadmill is going to have a computer that has the running EKG. It's also where you'll document any information that you take on from the stress test, any shortness of breath, any other problems. If there's any changes with their EKG, you want to document that. It will also tell you what the stage time is. Stage time is going to be important because you need to know at the midpoint of each stage that you need to assess their vital signs. You also want to have the running total time of the test going as well. So on your computer for the stress test treadmill, you're going to have one clock that's running that has the stage time, one has total time. Okay? All right, so Kendall, let's have you go ahead and put the cuff on me. Now, I don't have the EKG simulator running, but you could imagine how much you've got the simulator running. We've all heard it before. It's constantly beeping. You've got you can just put a tiny bit of pressure on it. You've got the drone of the belt. You're going to have my footsteps on the belt making noise. The cardiologist is going to be talking. The patient may very well be talking. It gets to be a pretty chaotic scene. All right, I'm going to go ahead and start. All right, so my speed, I'm at 1.7 miles per hour, and I'm at 10% incline. And again, we're going to be here for 3 total minutes, but at the 1.5 minute mark is when you would have to ask me about the RPE, get my blood pressure, assess my oxygen saturation, document the EKG. I don't have the pulse oximeter. Now, when you guys go to take your blood pressures on your patient, you don't ever want to have the patient or yourself up against the treadmill in any way, shape, or form because you'll pick up treadmill vibration. And here in a minute, when I really crank this thing up, you're going to see it's not easy to get a blood pressure on somebody when they're exercising. It's something that you have to practice a lot. All right, so now I'm at 1.5 minutes, so let's go ahead and get a pressure. All right, now you're going to want to put your thumb on top, hold my arm tight. You're going to have to really put some force on there. Be careful not to lean against the treadmill.
140 over 96.
Okay. All right, it's going to go up with exercise. Now, you also want to ask me about that chart.
How would you say?
Mr. Bernard, how would you rate your exercise on that chart? Okay, so after she asked me how I would rate my exercise on that chart, I would say, in this example, light. Okay, so it's 2 to 3. Okay, she's also documenting at that point, pushing the button on the EKG to document a 10 to 15 second strip. It would be automated. Once you hit document, it's going to run a 10 to 15 second strip. Put the probe on my finger for pulse oximetry reading if it's not already on there. But now it's time to go up. Okay, you can't move that one so far. Remember, that's serving the purpose of being your device, and that's pretty much how they sit. Yep, it's tight. It's kind of a juggling act to get everything accomplished. Right. Put a little bit of pressure in that cup because it's about to slide off mine. Just a tiny bit. Yeah. All right, I'm going to have Kendall get this one, and then after Kendall gets this second stage, I'll have one of my other students step in. I want everybody to get a chance.
Now, would you ask them about their exercising, like, with every minute, or just?
Typically you want to wait till about that midpoint. You could be asking them a little bit early, but in 10 seconds, that would be the midpoint. Okay.
How would you rate your exercise?
Probably moderate. Bigger women, bigger down. It's going to be important that you have a good grasp of the head of that stethoscope. Otherwise, when I start running here in a minute, you're not going to pick up anything.
178 over 102.
Okay. All right. 45 seconds, I'm going to go up. All right, my next medical assistant. A little bit of air in that cup. So let's see. Why don't you go ahead and pull it off and get it back on there. So just about to crank it up. Yeah, where's the gauge? That's a good way to see it. Now, it's not easy for me to be holding on with just one hand and having this go on. So you're going to have to get used to working around the patient because they're not going to be as strong and able to hold on the way I am. Okay. Mm-hmm. It's still moderate. High and moderate. Again, you ask me if they had any chest pain, any shortness of breath, anything like that as well. All right, Sheila, you're up. All right, don't be sitting down over there. Come on, team. All right, here we go. Nope. 10.5. On top of my arm, because if I bump up again, no. Put your thumb on top of this. Your thumb. So you need to hold it underneath my arm and bouncing up against that. Yep. No. Put your thumb on it. So you can hold the rest of my arm with your hand. Help her out, Kendall. There you go. There you got it. You're going to have to take a firm grip on this because, I mean, look how much I'm moving. It's not easy for me to try to hold my arm out like this. You guys have to hold their arm. Okay, about to go. That's part of it. It's not like I can slow down. Okay. Practice, okay? Now, the next stage, we're already in the next stage now. No, you're not done yet. It's too late, you've already blown that stage. So, that's why it's so important, okay, that you guys practice these skills and you're not fumbling around with these skills whenever you're just practicing on each other seated and resting. Because now, when it really matters, you've got to be proficient. Now, when I cool down here in a second, you guys got to start doing all of that in 1 minute. Not 3 minutes. Cool down is every minute. All right, go ahead and try to get one on me now. Make it quick though, because I can't hold it like this very long. All right, come on. You're not even moving my arm. Hold on for the treadmill. All right, so we cooled down. So, the treadmill for stress test, you will hit a button and cool down. It'll bring you down to 0. When I stop, okay, you're going to put me over there on the bed. But again, all the while the treadmill's slowing down, you've got to be getting those vitals every minute.
Now, would you continue through the rest of the steps?
Continue. You don't need to ask me how hard I'm working, because I'm not working now. But everything else needs to be continued. Blood pressure, asking me if I'm having any chest pain, shortness of breath. Anything? No.
Are you sweating excessively?
No. Now, most of the problems associated with the stress test will actually occur when they're resting, not when they're exercising. The myocardium has been pushed to the max, and once you get them laying down, the myocardium sometimes just can't take anymore. And this is when you'll start to see arrhythmias and changes with the ST segment. All right, let's get one of you all to take it. Again, we don't want to take the cuff off once we get it on. It's okay. That's why we're here. We're practicing. And I didn't want to be singling anybody out, but what I just wanted to emphasize was how important it is for you guys to practice these skills so you've mastered them, that you don't have any trouble with blood pressures. When you do this, you can't be fumbling around with your cuff, with the valve, not having a good grasp and supporting the patient's arm. You've got to master all of that before you get into a cardiologist's office and start doing stress tests. It's okay. That's why we're here to practice. Okay, Madeline, you're up. All right, now I went into stage 5, okay, which is 5.0 and 18. Having said that, let's say it takes me 10 minutes to cool off and come back to baseline. How many complete sets of vital signs would have been assessed on that patient throughout the course of this stress testing procedure?
5, 4, 5.
How many total? Remember, you're going to do supine and seated, standing, hyperventilating. How many total?
9.
No. It takes me 10 minutes to cool down, and we take one every minute. Okay. Plus 5 stages, 1 complete set of vital signs in each stage, plus supine, seated, standing, and hyperventilating.
19.
All right, so you would have assessed 19 total sets of vital signs during this procedure. Take another shot. You can still lift my arm up, put your hand underneath of it, so you can really push in with that thumb. Okay. Get that valve really shut. Okay. Yeah, you can go ahead and take it off. All right, let's assume that I'm back to baseline now. Okay, say 10 minutes have gone by like we used in our example, and now I'm back to everything at baseline. Heart rate's the same, blood pressure, all of that. Now, the last thing that you guys are going to need to do to complete this, of course, you have to document, but you also need to calculate what's called the rate pressure product or the double product. Okay? Rate pressure product is going to be the highest heart rate achieved. And let's just say since my max heart rate was 173, let's say they got me to 173. Then you take your systolic blood pressure, your highest systolic blood pressure, multiply that by your heart rate. So it's going to be 173 times 180. Okay? That came out in our example to 31,140. So the rate pressure product was 31,140. Now, on our chart, we had the double product or the rate pressure product. If it's higher than 30,000, it's rated as a high rate pressure product. High intermediate 25,000 to 30,000. Intermediate 20 to 25,000. Low intermediate 15 to 20,000, and then low is 10 to 15,000. Rate pressure product is going to be an assessment of the internal cardiohemodynamics, and it's going to measure the total amount of work that the heart had to do at peak output, okay, the highest level of heart rate and the highest systolic blood pressure. That's why it's so important for the cardiologist to get really strong readings on blood pressure, get the EKG documented, so they can calculate as accurately as possible everything that they need to assess their patient thoroughly. Okay, it is challenging, as you guys could see. It's very challenging to perform a stress test. Okay, and I wanted to make you guys sweat a little bit, just like I was sweating up there on the treadmill, because I want you guys to understand that perfecting your basics when you have a resting patient is something that's going to pay off when you go and have a patient exercising and you have to take 19 sets of vital signs in a relatively short period of time. You're doing a complete assessment of your patient as well as assessing their vital signs during each of those 3-minute stages, and it's compressed down to 1 minute at a time that you're doing that exact same thing when we're in cool down mode. Okay, so again, it's very important that you guys take every opportunity that you have in class to practice your blood pressures, really perfect your skill, so that way when you get into a much more intense environment and you don't have a patient just resting, that you're ready to step up and utilize those skills that you've mastered in a situation like this where it's not your normal environment for assessing your patient. All right, does anybody have any questions?
Just as an example, you said as of on here, your heart rate should be 173, and the highest blood pressure that we got from that was 218.
Okay, I just use that as an example.
Yeah,
right.
that's what I would use 218
Yep.
times the 173.
Exactly. I couldn't remember off the top of my head. I remember we used 180 last class for it, and so we had written down the numbers, but you're exactly right. If we had 218 today for the systolic, we would have used 218 and our theoretical max today of 173.
Now, what would be considered normal for the double for the heart pressure?
Well, typically, if somebody can't push themselves very far, then that number isn't going to be, that high. So it's not exactly that we're looking for a low number or a set range. What we're really looking to do is assess how much work their heart had to overcome during the peak level of that stress test. All right, any other questions? Go ahead.
When you finish getting back to baseline when you're supine, don't you sit up and take it, or am I?
You could.
Okay.
You very well might do that, because you would want to make sure that, again, your patient didn't go orthostatic when they sat up. So it wouldn't be a bad idea to take an additional pressure when they sit up from being supine for several minutes, and then also when they stand up. Okay, that's definitely a good idea, because we don't want to have any of our patients passing out. Stress testing is very intense. To be honest with you, I did a stress test and I ran even more this morning than I did today, and my legs are really feeling it, especially this left leg. So your patients who are not in very good shape, they may very well be very debilitated after this test, and you want to make sure that they're not at a risk to pass out. You also wouldn't want them driving themselves home without somebody, to take them. Okay, you would not want them behind the wheel. Okay,
So
any other questions?
Would you keep them for how long after doing this?
Again, you'd want to make sure that everything returned to baseline. Okay, that's your key. Some people may return to baseline in a relatively short period of time. That's another key indicator of how good of shape that somebody is in, how quickly they return to baseline. Other people, it may take them a very long time to return to baseline. Oh, yeah. When you guys get your patient off of that treadmill, make sure that you hold on to the patient. Okay, they may very well experience vertigo going from having the pavement moving under their feet to now not having the pavement moving under their feet. Okay, you want to give that patient a minute or so to stand at the treadmill once the belt stops and kind of get their legs back under them. Typically, I would always say, Mr. Bernard, it's going to feel like you're getting off of a boat right now, so please just take a minute to get your legs under you. Now, the other thing too is when they go to step up on that treadmill, because they may not be used to stepping up and everything kind of takes on a different perspective when they're standing on that treadmill, they may experience vertigo then as well. That's why stress test treadmills have the deck almost brushing the floor. You don't want the patient stepping up any higher than what's necessary. That's a commercial treadmill. The setup is a little bit different. But on a stress test treadmill, the belt practically is at the floor level, just to make it easier for the patient to step up and make it less likely for them to have vertigo because of stepping up on the deck of the treadmill and being up higher than what they're used to. Any other final questions? All right, very good, very good.